Okay, so this gets us to the next question, that is question number 156. This gets us to the next question, that is question 156. Rheumatoid arthritis, it is associated with all except the neutrophils reduce, the macrophages increase, the lymphocytes increase. What it is not associated with is increased neutrophils. The answer is D, that is increased neutrophils. Increased neutrophils, it is not associated with rheumatoid arthritis. So this gets us to the examples of leukocyte mediated injury. Examples of leukocyte mediated injury. Examples of leukocyte mediated injury. First point, I can divide them into acute and chronic. I can divide the leukocyte mediated injury into acute and chronic. Starting with acute leukocyte mediated injury, the examples are ARDS, acute respiratory distress syndrome. We have already seen the pathogenesis of this. The main cells involved are the neutrophils. Next is acute transplant rejection. Acute transplant rejection, where the main cells were lymphocytes. Transplant rejection. Next is asthma, which is associated with eosinophilia, and septic shock, which is associated with the secretion of all the cytokines and chemokines. These are the acute ones. Coming to chronic, the first and the main one, which was even asked in the question, is rheumatoid arthritis, which is associated with lymphocytes and macrophages. Lymphocytes and macrophages. So lymphocytes increase, macrophages increase, neutrophils reduce. It is not associated with increased neutrophils. Next is atherosclerosis. Atherosclerosis, that is associated with macrophages and lymphocytes again. Next, chronic transplant rejection. Chronic transplant rejection, again with both macrophages and lymphocytes. Chronic transplant rejection. And this gets us to the last one, that is pulmonary fibrosis, which is associated with macrophages and fibroblasts. Macrophages and fibroblasts. Macrophages and fibroblasts. This is the examples of leukocyte mediated injury. Leukocyte mediated injury. Next, this gets us to the next question, that is question number 157. Question 157. First point, old male with history of long intake of antibiotics. Diagnosis. The minute I see this, I am able to see the presence of the colon, the mucosal surface of the colon, which is covered with yellow-green exudate, making this as pseudomembranous colitis. So question 157, the answer is A, that is pseudomembranous enterocolitis. That is pseudomembranous enterocolitis. Pseudomembranous enterocolitis. What we saw in the image, was the mucosal surface of colon. Mucosal surface of colon covered with yellow-green exudate. Covered with yellow-green exudate, making it as pseudomembranous colitis. Pseudomembranous colitis. Next, this gets us to the next question, that is question number 158. This gets us to question 158. what we see here is morphological finding of kidney. Which lesion? The minute you see this, you are able to see the flea-bitten appearance of the kidney. You have the presence of multiple small hemorrhagic spots on the renal capsule. Flea-bitten appearance of the kidney, which is a feature of malignant hypertension. Which is a feature of malignant hypertension. Malignant hypertension. So what the gross showed you was multiple small petechial hemorrhages. Multiple small petechial hemorrhages on the outer surface of the kidney, occurring because of rupture of capillaries. Occurring because of rupture of capillaries on the renal capsule. Because the blood pressure is very high, because the BP is extremely high, the capillaries, they rupture on the renal capsule, giving it the classical flea-bitten appearance. Giving it the classical flea-bitten appearance of the kidney seen in malignant hypertension. Another point that can be asked with this is, what are the other causes? What are the other causes associated with flea-bitten appearance? One, obviously you know, is malignant hypertension. Malignant hypertension. The other diseases associated with this are PSGN, post streptococcal glomerulonephritis, PSGN, SABE, that is subacute bacterial endocarditis, SABE, that is subacute bacterial endocarditis. Next, venous granulomatosis, and HSP, Hinoch-Schönlein purpura, and HSP. These are the diseases associated with flea-bitten appearance of the kidney. Next point, what can also be asked is, this flea-bitten appearance, it is not seen in diabetic nephropathy. This again is important. It is not seen in diabetic nephropathy. Done. Next, this gets us to the next question, that is question 159. This gets us to the next question, that is 159. Post-renal transplant, complaints of chronic renal failure, urine microscopy, identify the structure with the arrow. Now what you see here is a urine cytology. This is a urine microscopic sample, urine cytology, showing the presence of lymphocytes and macrophages. These cells, the bigger ones, the ones I am showing with the arrow, the bigger ones with foamy cytoplasm, they are the macrophages, the smaller one are the lymphocytes, with presence of hyaline casts. So have a look at this. This is what hyaline casts look like. Look at the microscopy of a hyaline cast. This is what it looks like. So the answer is D. Question 159. The answer is D. That is hyaline casts. Hyaline casts. Next point. Before we go further, let us have a look at few other casts, starting with Vaxicasts. Vaxicasts, now what are these? In chronic renal diseases, some casts become denser in appearance. In chronic renal diseases, some casts, they become denser in appearance. They become denser in appearance and are easily visualized. Why? Because of their high refractive index. Because of their high refractive index. That is a Vaxicast. That is a waxy cast. So they are seen in chronic renal diseases. Next, before we go further, let us see what they look like. This is a waxy cast. What you have here is the presence of a waxy cast. Next, the next is an RBC cast. RBC cast. RBC cast, it would be composed of RBCs. They are seen in various diseases like glomerulonephritis, lupus nephritis, renal infarction, renal vein thrombosis, and malignant hypertension. That is the presence of an RBC cast. So RBC casts, they are seen in numerous diseases, and this is what they look like. It shows the presence of RBCs. You are able to make out the round cells. Let me mark it for you. In this, you are able to make out the presence of RBCs entrapped in the cast. This is an RBC cast. Next is a WBC cast. What you see here is the presence of WBC cast. You are able to make out all these as leukocytes. WBC casts, which are seen in interstitial nephritis, and pyelonephritis. So we have seen three main casts: RBC casts, WBC casts, and waxy casts. The Heron cast was the one that was given in the options question itself. Next, this gets us to the next question, that is question 160. DVT, that is deep vein thrombosis, is a manifestation of Leiden mutation. Question 160, the answer is B. Question 160, the answer is B, that is Leiden mutation. So what the examiner was asking you, that deep vein thrombosis, it is a thrombotic condition. So what are the causes of thrombophilia? I can divide the causes of thrombophilia into primary or the genetic causes, and secondary or acquired causes. So starting with the primary causes, the main causes factor V Leiden mutation. The main causes factor V Leiden mutation. Factor V Leiden mutation. In this, there is a glutamine to arginine substitution. Where at the 516th amino acid. Glutamine to arginine at 506th amino acid. Because of this, the factor V is resistant to cleavage and inactivation. It is resistant to cleavage and inactivation by protein C. As a result of which the factor V increases, making it a prothrombotic condition. Factor V Leiden mutation. This is the most common inherited cause of thrombosis. Most common inherited cause of hypercoagulability or thrombosis. Next, the other genetic causes are, it can also be associated with the prothrombin gene mutation. Also associated with the prothrombin gene mutation, which in turn elevates the prothrombin levels. Next, elevated homocysteine. Which causes both arterial and venous thrombosis. Elevated homocysteine, which causes both arterial and venous thrombosis. And the last cause, and the last primary cause, is the presence of deficiency of, it is the deficiency of antithrombin 3, protein C and protein S. These are the primary or genetic causes of thrombosis, that is factor V laden mutation, prothrombin gene mutation, elevated homocysteine, and deficiency of antithrombin 3 and protein C and protein S. Next, this gets us to the secondary or the acquired causes. Of thrombosis. The secondary causes are APLA, anti-phospholipid antibody syndrome, APLA. Drug induced, that is, it can be because of OCPs, estrogen, or HIT. HIT is heparin induced thrombocytopenia. HIT, that is heparin induced thrombocytopenia. HIT. Next, other causes are DIC, TTP, and nephrotic syndromes. DIC, TTP, and nephrotic syndromes. These are the secondary or the acquired causes of thrombosis. Done. So, factor V laden mutation was the answer to the question, because what was asked was DVT is a manifestation of factor V laden mutation. Next, the gene involved in Cowden's syndrome. The gene involved in Cowden's is PTEN. Cowden's syndrome, it is associated with abnormalities in PTEN. So question 161, the answer is A, that is PTEN. The answer is A, that is PTEN. So before we go further, we have already made the list of diseases with various syndromes associated and stuff. So just one point with this, Cowden's syndrome, it is associated with PTEN mutations. The gene involved is PTEN. I am not going to get into the other gene mutations with their abnormalities. Cowden's, it is associated with GI lesions, that is hematomatous polyps. It is associated with hematomatous polyps, lipomas, associated with hematomatous polyps, lipomas, and increased risk of colon cancer. Next, you very well know FAP, familial adenomatous polyposis, APC gene mutation, HNPCC, hereditary non-polyposis colon cancer, the MSI pathway mutations, Peutz-Jeghers syndrome, STK11. We have already done those. Next, this gets us to the next question, that is question 162. This gets us to the next one, 162. 20-year-old girl, soft form nodule on chest, not increasing. Now, what you have here is the presence of a nodule on the chest which is red protruding nodule, which microscopically. See, the minute we see gross, it is not Paget's disease. It's not breast. It is not Paget's disease of the breast. Firstly, Paget's usually occurs around the nipple. Next, it shows the presence of exudative, erosive, infiltrating lesions. It's a very dirty looking lesion. This is not that dirty looking. Paget's is out. It is not a lipoma. Lipomas, they are subcutaneous. They can be anywhere. They can be subcutaneous, intramuscular, whatsoever, but they are covered with skin. They are mobile. They are well defined lesions. Maybe mobile, maybe immobile, but they are well defined and have usually the color of the skin. This is red in color, so lipoma is out. Next, what the microscopy is showing us is the presence of numerous capillaries or numerous blood vessels, giving it the classical appearance of a hemangioma. So question 162, the answer is A, that is, this is a hemangioma. This is a hemangioma. Next point, hemangiomas. Hemangiomas, they are most common tumors of infancy. They are the most common tumors. Hemangiomas, just a sec. Hemangiomas, they are the most common tumors. Most common tumors of infancy. They are the most common tumors of infancy. Next point, in children. In children, they are located in skin of the face. They are located in face and scalp. Face and scalp, where they produce flat to elevated, where they produce flat to elevated red blue masses. Red blue masses. The flat lesions, they are also referred to as the port wine stains. They are flat lesions, they are also mentioned as the port wine stains, which regresses spontaneously. Which regresses spontaneously. So the port wine stains in children can even regress spontaneously. This is important, so I'm just getting into this hemangioma, that is the port wine stain. There are numerous other kinds. Let's not get into those. They have not been asked in the previous 3 to 4 years. Simple fact: port wine stain, flat lesions seen in children which can regress spontaneously, and it is the most common tumor of infancy. Next, this gets us to the next question, that is question 163. This gets us to the next one, that is question 163. Which of the following is seen in the peripheral smear? Peripheral smear, it shows the presence of band cells. You are able to see this cell, the one I am showing with the arrow. This is a band cell. Teardrop RBCs, these are the teardrop RBCs, and hyposegmented neutrophil. Please note, this is not a nucleated RBC. Nucleated RBC, it should have a hemoglobinized cytoplasm. It looks like the cytoplasm of the RBC. This is a hyposegmented. These are the hyposegmented. It has 3 lobes. These are unilobed or bilobed neutrophils. Trilobed, bilobed, and a unilobed neutrophil. So the answer is A. That is, it shows the presence of band cells, teardrop cells, band cells, teardrop cells, and a hyposegmented neutrophils. Why hyposegmented? Because they were trilobed, bilobed, as well as unilobed neutrophils. Next point. On the other hand, now that we are writing this, let us see this also. On the other hand, a hypersegmented neutrophil, is seen in megaloblastic anemia. I can rephrase this as hypersegmented neutrophil This is the first manifestation. This is the first manifestation of megaloblastic anemia. First manifestation of megaloblastic anemia on peripheral smear. Hypersegmented neutrophil. Next point, how many lobes of the neutrophils are there in a hypersegmented neutrophil? More than 5 lobes. More than 5 lobes in even a single neutrophil, or 5 lobes in 5% neutrophils. This is what we mean by a hypersegmented neutrophil. Next, this gets us to the next question, that is question 164. This gets us to the next one, that is question 164. What we have here is the presence of person paresthesia in hand, absent ankle jerk with Babinski sign, MRI spine is also performed. See, when we have absent ankle jerks, we are thinking of neurological manifestations with the peripheral smear showing the presence of large RBCs, macrocytes, with presence of a hypersegmented neutrophil. So even if nothing was given in the history, nothing was written as a written MCQ, you just had this slide also, then also the answer that you are going to think of is macrocytic anemia. Macrocytic anemia. So question 164, what you have is a macrocytic anemia. Macrocytic anemia. We have seen the size of the RBCs. There was variation with large size RBCs with hypersegmented neutrophil. We have already seen that in the previous MCQ. What did the MRI show? MRI indicated involvement of dorsal columns. It indicated involvement of dorsal columns. Not interested at all. We are not radiologists. Let's not even get into diagnosing MRIs just by seeing them. Hardly matters. Nothing else is needed except this peripheral smear, macrocytic anemia. Next, this gets us to the next question, that is 165. Forget the question. Let us see what, though let us read it up. Pattern of inheritance is asked in the image. The image that you have in this, it shows the presence of large elliptical cells. Large elliptical cells, you are able to make out those are the predominant shape of the RBCs. So inheritance is asked with presence of elliptical cells. So obviously this is hereditary elliptocytosis, which is autosomal dominant in appearance, which is autosomal dominant in inheritance. So just one word, the answer is autosomal dominant. Autosomal dominant, and the image was that of hereditary elliptocytosis. Hereditary elliptocytosis. Hereditary elliptocytosis. Autosomal dominant inheritance. Next, this gets us to the next question, that is question 166. Question 166. What we have here is IPI, International Prognostic Index for lymphomas, include the following except stage of the disease is included, number of extra lymphatic sites is included, so is LDH, hemoglobin and albumin is not. So the answer is D, that is hemoglobin and albumin. And let us now see what we mean by International Prognostic Index. International Prognostic Index, let me write it again. So let us see what we mean by this. International Prognostic Index. The parameters which are included in International Prognostic Index are, the parameters are age more than 60 years, age more than 60 years, stage 3 or 4 disease. Stage 3 or 4 disease. Next, elevated serum LDH levels. Elevated LDH. Next, more than one extranodal site. More than one extranodal or extralymphatic site of involvement. More than one extranodal site of involvement. And the ECOG score. ECOG score. ECOG score or ECOG performance status of 2, 3 or 4. 2, 3 or 4. That is, ECOG score is 0 is asymptomatic. When we talk of ECOG score, just listen to this, you need not remember it. ECOG score of 0 is asymptomatic. ECOG score of 1 is symptomatic but ambulatory. The patient is able to do its normal routine functioning and stuff. ECOG score of 2 is symptomatic with less than 50% activity during the day. 3 is more than 50% but is not bed bound, whereas 4 is completely disabled or bed bound. Not interested. All I'm interested is these are the international prognostic index criteria. Hemoglobin and albumin is not one of them. Hemoglobin and albumin is not one of them. Next, this gets us to the next question, that is question 167. This gets us to the next question, that is question number 167. Let us have a look at the question. 167. Test used to differentiate maternal hemoglobin from fetal is the Kleurer-Buttke test. Question 167. The answer is A, that is Kleurer-Buttke test. Kleurer-Buttke test. Kleurer-Buttke test. This is the one which is used to differentiate maternal hemoglobin from fetal hemoglobin. Maternal from fetal hemoglobin. Whereas to look for the amount of hemorrhage into the maternal hemoglobin, that is APT test. Look for fetal hemorrhage, APT test. To look for to differentiate maternal from fetal hemoglobin, Kleurer-Buttke test. Next point. So before we go further, let us have a look at what we mean by Kleurer-Buttke test. Kleurer-Buttke test, it measures the amount of fetal hemoglobin. It measures the amount of fetal hemoglobin transferred from a fetus to mother's bloodstream. Amount of fetal hemoglobin transferred from fetus to the mother. That is Kleurer-Buttke test. What do we do in this? It is usually performed in Rh negative mothers. Because if the child is Rh positive, to know how much fetal blood has gone to the mother, so performed in Rh negative mothers, because this is required to determine the dose of Rh immunoglobulin. That needs to be given to the mother to prevent antibody formation. Rh immunoglobulin that needs to be given to the mother to inhibit Rh antibody formation. This is Kleurer-Buttke test. Next point, what is the principle of the test? The principle of the test is the principle is there is differential resistance of fetal hemoglobin. There is differential resistance of fetal hemoglobin to acid as a result of which the fetal hemoglobin, it is resistant to acid. As a result, when we add acid, the adult hemoglobin is lysed, the fetal is not. So the principle of Kleber-Betke test is differential resistance of fetal hemoglobin to the acid. Sufficient to know this much. Next, this gets us to the next question, that is question 168. All are implicated in colon carcinoma by the classical pathway except MSI. See, in this the answer is D, that is mismatch repair genes. This gets us to the pathways of colon cancer. There are two main pathways of colon cancer. The adenoma carcinoma pathway and the MSI pathway, that is microsatellite instability pathway or the DNA mismatch repair pathway. Now, in the adenoma carcinoma pathway, the genes involved are APC, WNT, beta catenin and KRAS. We have already seen this. Adenoma carcinoma pathway, the genes involved are APC, WNT, beta catenin and KRAS, versus the MSI pathway where the genes involved start with M. MUTYH, MSH2, MSH6, MLH1, PMS1 and PMS2. Except PMS1 and 2, all the genes involved in the MSI pathway start with M. So these were the two main pathways, adenoma carcinoma and MSI pathway. In the question given, APC, WNT, KRAS, beta catenin, they were of the same adenoma carcinoma pathway except mismatch repair genes which are involved in the MSI pathway. So the answer is D. Next, translocation 814 is associated with c-Myc proton gene. We have already discussed this when we were discussing buckets. Question 169. Let me write it again. Question number 169. The answer is B, that is c-Myc amplifications or c-Myc proton gene mutation. Let me rephrase it. Burkitt's c-Myc proton gene mutation. So let us have a quick recap of the translocations in Burkitt's. Translocation in Burkitt's lymphoma. The most common translocation is translocation 814. Others are translocation 28 and 822. Which chromosome is common? Chromosome 8. Why? Because it is associated with c-Myc mutations. So the gene involved, c-Myc. Next, this gets us to the next question, that is question number 170. This gets us to 170. Mason's trichrome. This stain is used for the demonstration of mature collagen in tissues. See, let us have a look at this again. It is a renal stain. Mason's trichrome, it is a renal stain. So before going further, the answer is C, that is mature collagen in tissues. mature collagen in tissues. And this gets us to a subtopic in stains, that is renal stains. This gets us to a subtopic, that is renal stains. We have already discussed the various stains which are used for various components, that you know. Kidney is special, so the various renal stains are PAS, that is periodic acid Schiff. PAS, it stains the basement membrane. It stains basement membrane, mesangial matrix, basement membrane, mesangial matrix, tubular epithelium, basement membrane, mesangial matrix, tubular epithelium, and Bowman's capsule. So PAS, it stains basement membrane, mesangial matrix, tubular epithelium, and Bowman's capsule. This is the most useful stain in renal biopsy. This is the most useful stain in renal biopsy. Next, the next renal stain is MT, that is Mason's trichrome. This was what was asked in the question, Mason's trichrome. The name tells you everything. Trichrome, 3 colors. So the 3 colors are blue green for collagen. The 3 colors are blue green for collagen, red for muscle, and black for nuclei. So Mason's trichrome. Hence it is used to differentiate smooth muscle hypertrophy, from fibrosis. What does this mean? Smooth muscle hypertrophy and fibrosis look similar on HND. They look similar. On the other hand, on MT, smooth muscle hypertrophy would be red, whereas fibrosis would be blue-green. This was what was asked. It is used to detect mature collagen or fibrosis. The last renal stain is SM, that is silver methenamine. The last renal stain is SM, that is silver methenamine. SM, it is used to differentiate hyaline deposit from sclerosis. SM, silver methenamine, it is used to differentiate hyaline deposit from sclerosis. Sclerosis is SM positive, that is a silver methenamine stains sclerosis. Done. Next, this gets us to the next question, that is question 171. This gets us to the next question, that is 171. What we have here is translocation X18. It is characteristically seen in synovial cell sarcoma. Translocation X18, the answer is A, that is synovial cell sarcoma. It is seen in synovial cell sarcoma. We have already made the list of translocations, the fusion transcripts, and the tumors associated. So just one point, translocation X18, synovial cell. I'm not going to go into more details. We have seen those with ALL, the good prognosis, AML, good prognosis, poor prognosis, MDS, poor prognosis, whatsoever. We have done so. Next, this gets us to the next question, that is question 172. Now this is interesting. What we have here is 25 male, history of celiac. Several days after an upper respiratory tract infection, he noticed dark brown urine for the 3 days. So there is hematuria after respiratory tract infection. It became clear and yellow, only to become red brown again in a month. So recurrent gross frank hematuria. the protein level is now 200. Which of the following is most likely? Recurrent gross frank hematuria is IgA nephropathy, or Burgess disease. So what is the site of deposit in IgA nephropathy or Burgess? It is a mesangial deposit by immunofluorescence. So question 172, the answer is C, that is mesangial IgA deposit. Mesangial IgA deposit by immunofluorescence. We have made the master table of sites of deposits with the diseases associated. The trick in the question was that you had to recognize it as recurrent gross frank hematuria. This was the trick in the question. Recurrent gross frank hematuria seen in IgA nephropathy. Or Burgess disease. The site of deposit in this is a mesangial deposit. And microscopically it presents as mesangioproliferative glomerulonephritis. Next point, incubation period. Again, this is asked. The incubation period for IgA nephropathy after respiratory tract infection is 1 to 2 days. So how do we differentiate IgA nephropathy from PSGN? Both occur after respiratory tract infection. In case of PSGN, the incubation period is 1 to 2 weeks, whereas in IgA nephropathy, the incubation period is 1 to 2 days. Next, this gets us to the next question, that is question 173. This gets us to the next one, that is question 173. Maximum endocapillary proliferation is seen in PSGN. The answer is D, that is PSGN, post streptococcal glomerulonephritis. This gets us to the microscopy in PSGN. First point, PSGN, it is associated with massive endocapillary proliferation. What do we mean by this? The lining of the capillaries is endothelial cells. So endothelial cells, they proliferate, as a result of which the lumen of the capillaries is reduced or obliterated, leading to reduction or obliteration of capillary lumen. So massive endocapillary proliferation leading to reduction or obliteration of capillary lumen. The next light microscopic feature of PSGN is it is also associated with neutrophilic infiltration. Obviously, because it is an infective lesion, so neutrophilic infiltration is a feature of PSGN. Next, immunofluorescence. Please put a double star on it. Immunofluorescence shows the classical lumpy bumpy. Granular deposits. This is not my language, this is what WHO says for PSGN, giving it the classical starry sky appearance. This is PSGN. Next, this gets us to the next one, that is question 174. Question number 174. What you see in this is patient with achlorhydria undergoes a Schilling test. In Schilling test, we give intrinsic factor. Which of the following is seen in typical pernicious anemia associated with gastric atrophy? So, what pernicious anemia is antibodies against intrinsic factor. So, when vitamin B12 is given orally, the patient will not be able to absorb it. But when intrinsic factor is given to the then it is absorbed. So what we see in this is radioactive vitamin B12 is not detected in the urine, but option C, but it is detected after the addition of oral porcine intrinsic factor. This is typical pernicious anemia associated with gastric atrophy, because the body is not producing intrinsic factor, it has antibodies against it, but when you give it, then it is detected in urine. So question 174, the answer is C. Next, this gets us to the next question, that is question 175. So question 174, the answer was C. This gets us to the next question, that is question 175. Which of the following plasma cells? So nothing to think, nothing to ask or whatsoever, has been asked repeatedly. Plasma cells or multiple myeloma is associated with interleukin 6 overexpression. Which is a feature of multiple myeloma. Interleukin 6 overexpression, which is a feature of multiple myeloma. Next point, interleukin 6 multiple myeloma, we have already discussed the IMWG criteria, International Myeloma Working Group criteria. We saw it was associated with interleukin 6 overexpression. Now, another malignancy associated with interleukin 6 overexpression. The first one was multiple myeloma, has to be remembered, repeatedly asked. The next is cholangiocarcinoma. The next malignancy associated with interleukin 6 overexpression is cholangiocarcinoma. This has to be remembered. Next, this gets us to the next question, that is question number 176. Question 176. Histology of neuroblastoma. Now, in the image, in this question, they have made it extremely easy by even giving the name of the disease as neuroblastoma. Most probably, when in the question paper, when you will get it, neuroblastoma won't be mentioned, just image with the options, nothing other than that. This is the classical appearance of Homer-Wright pseudorosettes. What is a rosette? Rosette, it is a round arrangement of cells. Rosette, let me write for you, question 176, the answer is A. It was Homer-Wright pseudorosettes. Let us see this in slight detail. Rosette is a round arrangement of cells. Rosettes can be of two types. They can either be a true rosette or a pseudo rosette. True rosette shows the presence of a central lumen. True rosette shows the presence of a central lumen. I am not saying a blood vessel, but a lumen. Anything other than a lumen is a pseudo rosette. So neuroblastoma shows the presence of Homer-Wright pseudorosettes. It shows Homer-Wright pseudorosettes with a central neuropil. Why is it a pseudorosette? Because it does not have lumen in the center. What it shows is the presence of a central neuropil. So the pink structure that you were seeing in this, see, this is a round arrangement of cells with something pink in the center. This pink is the central neuropil. This is neuroblastoma. Next point, let us see one more feature in microscopy of neuroblastoma. Neuroblastomas, are they mature or are they immature? Blastoma, they are a immature tumor. So what is the maturity component? Maturity component of neuroblastoma. The maturity component of neuroblastoma is the presence of gangliocytic differentiation. Presence of gangliocytic differentiation and Schwannian stroma. The maturity component of neuroblastoma is the presence of gangliocytic differentiation and Schwannian stroma. This has to be remembered. This is the maturity component. So if the maturity component is present, it is good prognosis, whereas if it is absent, it is poor prognosis. So maturity component is gangliocytic differentiation and Schwannian stroma. If it is present in neuroblastoma, it is associated with a good prognosis. Next, this gets us to the next question, that is question number 177. Question 177. What we have here is glomerulonephritis associated with hypocomplementemia. Hypocomplementemia means the complement levels are reduced. All MPGN, lupus as well as PSGN are associated with hypocomplementemia. The answer is D, all of the above. It is associated with hypocomplementemia. So hypocomplementemia, it is seen in MPGN, PSGN and lupus nephritis versus normal complement levels which are seen in venous granulomatosis. Normal complement levels which are seen in venous granulomatosis, IgA nephropathy and HSP, Henoch-Schönlein purpura. So diseases associated with hypocomplementemia and normal complement levels. Next point, another question that is asked with respect to complement levels is in PSGN. This hypocomplementemia is temporary in nature and gets corrected within 8 to 10 weeks or 2 to 3 months. This hypocomplementemia, it is temporary in nature and gets corrected within 8 to 10 weeks or 2 to 3 months. Done. Next, this gets us to the next question, that is question 178. Question 178. What we have here is striped fibrosis of the kidney is seen in. This is a factual question. This has to be remembered and has not been asked frequently. So every paper will have about 10% of the questions which are new to stump you. So striped fibrosis, this is seen in cyclosporin toxicity. It is seen in cyclosporin toxicity. I am not interested in the details of this at all. Chances of this getting repeated are few. So cyclosporin toxicity. Next, this gets us to the next one, that is question 179. Now the minute we see this image, nothing else is required. Just have a look at the image. This is nutmeg liver. This is the classical image, has been asked last year in All India also. That is, this is 2018 May 2018 is going on. So this was All India 2016 exam question, nutmeg liver, which shows the presence of dark areas with pale ones, seen in chronic venous congestion, CVC liver. Now the answer is, what are the necrotic areas? The red areas are the necrotic areas. Have a look at option C. The red areas, the darker ones, are the necrotic areas near central vein. White areas are the viable fibrotic periportal areas. This is important. Nutmeg liver. Nutmeg liver. So question 179, the answer is C. The answer is C. That is, the red areas. Red areas are the necrotic areas near central vein. Red areas are the necrotic near central vein, and white areas are the viable fibrotic periportal areas. White are the viable fibrotic periportal areas. Viable fibrotic periportal areas. So red are the necrotic near the central vein, white are the viable. This is seen in chronic passive hepatic congestion. Seen in chronic passive hepatic congestion. Seen in chronic passive hepatic congestion associated with right-sided heart failure. Associated with, seen in chronic passive hepatic congestion associated with right-sided heart failure. Right-sided heart failure. First point. Next point, this is the classical appearance. This is called as nutmeg liver. This is the nutmeg liver. CVC, chronic venous congestion of the liver. Next, this gets us to the next question, that is question 180. Question 180. My mistake, guys, just a mistake. What we did is the nutmeg liver question was 180. Next, question 179. Let's have a look at this also. We have already made the list of stains and what they stain. Waldenstari stain is for H. pylori. Von Cosa is the most commonly used stain for calcium. Most common Von Cosa, most specific alizarin redness. Next, Romnowski stains. They are the ones used in hematology, whereas myelin is stained by Bilchowski stain. So question 179, the answer is D. The answer is D, that is Bilchowski stains. That is Bilchowski stains. So question 179, the answer is D, that is myelin is stained by Bilchowski stains. Next, this gets us to the next question, that is question number 181. We were already done with 180, that was nutmeg liver. This gets us to the next question, that is 181. The pedigree chart is shown which inheritance? Let us have a look at the pedigree chart. See, the mother is heterozygous, so there are two kids with heterozygous condition. None of the kids are affected, so autosomal dominant is out. Next, in case of a consanguineous marriage, the double line shows a consanguineous marriage. In case of a consanguineous marriage, one kid is affected. The two are heterozygous but normal. This is the classical pattern of autosomal recessive inheritance. So question 181, the answer is A, that is autosomal recessive. Autosomal recessive. Have a look at this again. Heterozygous, none of the kids are affected. They are heterozygous but not affected. In case of a consanguineous marriage, 25% of the kids are affected with the disease, 50% are carriers. This is autosomal recessive. Next, this gets us to, now look at this one. Look at the image. What you have here is fish. Fish stands for fluorescent in situ hybridization, fish. What we are able to see is the presence of three colors. One is green, one is red. So we have two green and two red colors, green and red, with presence of green and red fusing together to form a yellow color. This is translocation. So question 182, question number 182, the answer is B, that is, it is fish. Fluorescent in situ hybridization. It is extremely simple. Whenever we have to look at fusion transcripts, suppose translocation 922 leads to the formation of fusion transcript BCR ABL. I will give red color to BCR, green to ABL, hypothetically speaking. So what I should see is just two colors, red and green. If they are fusing together, they show the presence of a third color, that is a yellow color, which shows that the translocation is positive. So the same thing was happening in this. We had two red, two green with presence of a third color, that is a yellow color, which showed that it is a translocation. Next, this gets us to the next question, that is question 183. 183. What we have here is, it is the same image, just to stump you. What we see is kidney with a lesion on the upper part. So this can be adrenal or it can be renal cell carcinoma. So gross is not telling us anything. Now let us see the question. Abdominal mass, 5 months infant. Abdominal mass. Firstly, CT shows abdominal mass with calcifications. Biopsy was done, which shows the pattern of Homer-right pseudorosettes. The tumor is present as rosettes with a central neuropil. It is the same image that we saw earlier. This was primarily to tell you that be unbiased while seeing images. I know majority of you would have marked it as Wilms tumor. Not at all. Not at all. This is neuroblastoma with rosettes. So the answer is B. We have discussed this in detail already. You know it is a Homer-right pseudorosette with a central neuropil. So be unbiased while marking the questions. Next, this gets us to question 184. This gets us to question 184. What we see here is the presence of a Klima bone marrow aspirate needle. This is a Klima bone marrow aspirate needle. Klima bone marrow aspiration needle. This can also be used for bone marrow biopsies. So the answer to the question is A, bone marrow examination. It is a bone marrow examination needle. Next, this gets us to question 185. This is a muscle biopsy. Now muscle biopsy, this question is an extremely tough one, just to stump you. Have a look at this. What you are able to see in the muscle is the presence of long rod-like structures. This is nemaline myopathy. Nemaline myopathy. There is no way that I expect you to see this electron microscopic structure and mark it as nemaline myopathy. This was a tough, non-discriminatory question, and such questions would be present in all the papers. So question 185, the answer is D, that is nemaline myopathy. Nemaline myopathy. Just for the curious students, nemaline myopathy, it is a congenital myopathy. It is a congenital myopathy where the electron microscopy, it shows, electron microscopy shows aggregates of subsarcomal. Electron microscopy shows aggregates of subsarcomal spindle shaped particles. It shows subsarcomal spindle shaped particles. These spindle shaped particles are called as nemaline rods. So I do not expect you to see the image and mark it as nemaline. It is aggregates of subsarcomal spindle shaped particles, which are the nemaline rods. Nemaline rods. If you know this, fair enough. If the same image is repeated, mark it as nemaline myopathy. Otherwise, it was a very tough non-discriminatory question. Not to worry. Not to worry. Done. This gets us to the next question, that is question 186. Question 186. HHV8 is related to all except, we have just seen the tumors associated with HHV8, Kaposi sarcoma, primary effusion lymphoma, and Kesselman disease. It is not associated with adult T cell lymphomas. So the answer is C, that is adult T cell lymphomas. Adult T cell lymphomas. HHV8, it is not related to adult T cell lymphomas. Next, question 187. Question 187. What we have here is whole blood is used for the diagnosis of TB in gamma interferon assay. The answer is A, that is gamma interferon assay. Gamma interferon assay. What the examiner wanted to know in this case is gamma interferon assay. Gamma interferon assay, in this it is a interferon gamma release assay technique, IGRA, interferon gamma release assay. This is a in vitro blood test. This is an in vitro. It is an in vitro blood test of cell mediated immune response. In vitro blood test of a cell mediated immune response. Of a cell mediated immune response. It is an in vitro blood test of cell mediated immune response. This measures, they measure MEASURS. This measures T cell release. This measures the T cell release. Measures the T cell release of interferon gamma. Measures the T cell release of interferon gamma following stimulation by antigens. Following the stimulation by antigens specific to Mycobacterium TB. And following the stimulation of antigens specific to Mycobacterium TB. Following the stimulation of antigens specific to Mycobacterium TB. This is IGRA, interferon gamma release assay. This uses whole blood. Next, this gets us to the next question, that is question number 188. This gets us to 188. Biopsy of a small intestine with foamy macrophages. Nothing to think has been asked at least 15 to 18 times. What is the diagnosis? Whipple's disease. You very well know, this was this year's All India question also. Whipple's disease, it shows the presence of PAS positive. Microscopically, Whipple's disease shows the presence of PAS positive diastase resistant granules. PAS positive diastase resistant granules. Where do you see these PAS positive diastase resistant granules? In macrophages. And the most common location of these macrophages is lamina propria. Most common location of these macrophages is lamina propria. So the minute you see this PAS positive diastase resistant granules, that is the foamy macrophages, the diagnosis is Whipple's disease. Next point, Whipple's, it is caused by infection by an actinomycete. It is caused by infection by an actinomycete, and the name of this is Trophirema whippleyi. So Whipple's disease, it is caused by infection of an actinomycete, Trophirema whippleyi. Trophirema whippleyi. Next, of course, it shows a diagnostic biopsy. It has a diagnostic biopsy. We have already seen the diagnostic feature, that was Pas positive diastase resistant granules in neutrophils, in macrophages in lamina propria. Next, this gets us to the next question, that is question 189. L and H variety of RS cells are seen in lymphocyte predominant Hodgkin's lymphoma. The answer is A, that is lymphocyte predominant. The answer is A, that is lymphocyte predominant Hodgkin's lymphoma. Lymphocyte predominant Hodgkin's. So this gets us to the variants of RS cells. This gets us to the variants of Reed-Sternberg cells, or variants of RS cells. There are two main variants. The first is the popcorn cell or L and H cell, lymphocyte and histiocytic cell, seen in lymphocyte predominant Hodgkin's lymphoma. And the next is the lacunar type of RS cells. Lacunar type of RS cells, which are seen in nodular sclerosis. We have already seen this. We have seen their microscopies. We know what they look like. So popcorn cell or the L and H cell, lymphocyte predominant Hodgkin's, lacunar type, nodular sclerosis. Next, this gets us to question 190. Question number 190. Now, starting with this, what do we see here? Just a sec. Newly erupted teeth is covered by Nasmyth's membrane. This is it is a factual, non-discriminatory question. The answer is B. Newly erupted teeth, they are covered by Nasmyth's membrane. They are Nasmyth's membrane. They are covered by Nasmyth's membrane. What do we mean by this? Nasmyth's membrane, this is a thin membrane of tissue. This is a thin membrane of tissue, also known as reduced enamel epithelium. Also known as reduced enamel epithelium. Also known as reduced enamel epithelium. This reduced enamel epithelium, it is produced by ameloblast. Produced by ameloblast. Reduced enamel epithelium. It is a thin membrane of tissue, Nasmyth's membrane, also known as reduced enamel epithelium, produced by ameloblasts. This covers the tissue. This covers the tooth after eruption. This covers the tooth after eruption. This next point, this is usually worn away. This is usually worn away by mastication and cleaning. It is worn away by mastication and cleaning. Mastication and cleaning. So it also arouses the eruption of the teeth without bleeding. So worn away by mastication and cleaning. This is the Nasmyth's membrane. Sufficient. All of us MBBS students, we need not go into more details of teeth. Knowing this much tooth or teeth is sufficient. Let's leave it to the BDS students. Next, this gets us to the next one, that is 191. We have already seen this. Bernard-Sollier, deficiency of GP1B9. Glanzmann's thromboasthenia, GP2B3A. So question 191, the answer is B. GP1B. We have seen this. It is a defect in platelet adhesion. Next, question 192. Next point, question 192. Ret proton gene mutation. Again, we have seen this. We've seen it in thyroid. We have made the tumors and stuff, MEN syndromes. Ret proton gene mutation associated with MEN2. MEN2. Organs involved in MEN2. Organs involved in MEN2 were ATP, adrenal pheochromocytoma, thyroid, medullary carcinoma, parathyroid, hyperplasia, hyperplasia. Next point, you also know that MEN2 is associated with ret proton gene mutations present on chromosome 10. So what the examiner was asking you was ret proton gene mutation. The answer is A. That is, it is seen in medullary carcinoma thyroid. Ret proton gene mutation. Next, this gets us to the next one, that is question 193. Now, what we have here is 20 female with a painful blister in skin and oral mucosa. Direct immunofluorescence. Which of the following is not true? Not true is antibody against hemidesmosomes. See, this is pemphigus, fishnet appearance. This is pemphigus. You know that. Pemphigus is associated with antibodies against desmoglein 1, antibodies against desmoglein 3, and it is also associated with basement membrane deposition of IgG, most common DIF picture of bullous. What it does not show is antibodies against hemidesmosomes. So question 193, the answer is A, that is antibodies against hemidesmosomes. This is not seen. So this gets us to the antibody targets. For pemphigus. What we have here is the pemphigus vulgaris. It is associated with antigens which are desmoglein 3. This is a mucosal antigen. Desmoglein 3. This is mucosal. Next is desmoglein 3 and desmoglein 1. Desmoglein 3 and desmoglein 1, which are associated with mucocutaneous pemphigus vulgaris. Just a sec. Desmoglein 3 and desmoglein 1. Just a sec, guys, a slight technical thing. Desmoglein 3 and desmoglein 1, which is associated with mucocutaneous pemphigus vulgaris, and last is desmoglein 1 antigens, desmoglein 1, which is pemphigus foliaceus. So antigens, desmoglein 3 is mucosal, both 3 and 1 is mucocutaneous, desmoglein 1 is pemphigus foliaceus. So the most common bullous lesion is bullous pemphigoid, and the pattern of immunofluorescence is linear IgG deposit along basement membrane. Next point, the most common bullous lesion, this you know very well from derma. Most common bullous lesion is bullous pemphigoid. bullous pemphigoid, which is associated with the most common immunofluorescence pattern, which is linear IgG deposit along basement membrane. Linear IgG deposit along basement membrane. So we have seen that antibodies, they can be against desmoglein 1, desmoglein 3, or linear IgG deposit. So what is left is hemidesmosomes. Next, this gets us to the next question, that is question 194. This gets us to the next one, that is 194. Question 194. Let us have a look at it. What does RDW deal with? Extremely easy. Red cell distribution width deals with anisocytosis, whereas red cell anisocytosis, it is the indicator of anisocytosis, whereas that is altered size, whereas altered shape of the RBCs is poikilocytosis. So question 194, the answer is B, that is anisocytosis. What does this mean? Anisocytosis, this is altered size of the RBCs. This is altered size of the RBCs versus poikilocytosis, which is altered shape of the RBCs, RDW, that is red cell distribution width, is the indicator of anisocytosis, that is altered size. Next point, what is the normal RDW? It is 11.5. Normal RDW, it is 11.5 to 14.5%. Normal RDW is 11.5 to 14.5%. Next, this gets us to the next question, that is question 195. Question 195. Which of the following is a negative acute phase reactant? Negative acute phase reactant is albumin. Answer is A. Haptoglobulins, ferritin and CRPs are positive. So question 195, negative acute phase reactant, albumin. So let us make a table of negative and the positive acute phase reactants. Starting with positive acute phase reactants. They are CRP, that is C-reactive protein, serum amyloid A, haptoglobin, ceruloplasmin, alpha 2 macroglobulin, fibrinogen, and the complement proteins. These are the positive acute phase reactants. Positive means that they increase in inflammation. CRP, serum amyloid A, haptoglobulin, ceruloplasmin, alpha 2 macroglobulin, fibrinogen and complement proteins. These are positive acute phase reactants versus negative acute phase reactants, which are albumin, next transferrin, albumin, transferrin, transthyretin, and retinol binding protein. Retinol binding protein. This has to be remembered. Positive and the negative acute phase reactants has to be remembered. Next, this gets us to the next question, that is question 196. This gets us to the next one, that is 196. First point, question 196. Let us have a look at the question. 196. 50 male with recurrent diarrhea, histopathology is shown. What is the diagnosis? Let us slightly enlarge it. What this shows is the presence of transmural inflammation. See, it is intestine that is present, that is visible by the mucosa. It is a scanner view showing the blue cells, the light blue cells, which is transmural inflammation with ulcer. See, here the mucosal lining is present, here it is missing. Trace it with my pointer. Here the mucosa is missing with presence of blue inflammation. So transmural inflammation with ulcer is a feature of Crohn's disease. This was a slightly tougher image. Let us see the other ones. It is not adenocarcinoma colon, no glands are showing invasion, nothing. Non-Hodgkin's lymphoma, they will give you a higher power view showing the presence of lymphocytes, neither it is pseudomembranous colitis. So by default also, with the scanner view, transmural inflammation and an overlying ulcer, what I will think of is the presence of Crohn's disease. So the answer is D, that is Crohn's disease. I need not even tell you that transmural inflammation, serositis, granuloma formation and fissures are more common in Crohn's disease. I'll write it for you. Transmural inflammation, granuloma formation, serositis and fissures. Serositis and fissures are more common in Crohn's disease. They are more common in Crohn's disease. Next, this gets us to the next question, that is question number 197. Question 197. All are seen in development of T lymphocytes except TDT, CD34 and CD1A. They are the T cell markers, except PAX5, which is a B cell marker. The only point the examiner wanted you to know in this is PAX5 is a B cell marker. We have very well made the list of CD markers, pan B cell, T cell, leukocyte, lymphocyte, stem cells, everything. We've done that. The only point that the examiner wanted you to know was PAX5 is a B cell marker. Next point, the other B cell markers you know are pan B cell marker, CD19, pan B cell, it is positive on all the B cells. Mature B cell marker, CD20, immature B cell marker, CD10. We have already done that. Next, this gets us to the next question, that is 198. Which of the following can change the gene by methylation and acetylation without changing the content? Epigenetics. This is the definition of epigenetics. D. The answer is epigenetics. What do we mean by this? See, epigenetics, it refers to reversible heritable changes. Epigenetics refers to reversible heritable changes in gene expression. Reversible heritable changes in gene expression that occur without mutation, that occur without mutation. This is the definition of epigenetics. With the types of epigenetic modifications, there are three main types of epigenetic modifications, which are chromatin organization, chromatin organization that can either be inactive or active. Chromatin organization, inactive is heterochromatin, whereas active is euchromatin. Euchromatin, it is dispersed, heterochromatin is dense. So the first epigenetic first type of epigenetic modification what we are studying is the types of epigenetic modification. The first type is chromatin organization. The next type of epigenetic modification is DNA methylation. The next type of epigenetic modification is DNA methylation. DNA methylation, this results in transcriptional silencing. DNA methylation. And the last type is histone modifying factors. The last is the histone modifying factors. So types of epigenetic modifications, three types: chromatin organization, DNA methylation, histone modifying factors. Epigenetics, the most common is DNA methylation. Next, it refers to changes that occur without mutation. This was the definition of epigenetics. Next, this gets us to the next question, that is question 199. Question 199. If RB gene phosphorylation is defective, if the phosphorylation is defective, RB gene, it leads to cell cycle will stop at G1. If RB gene methylation is defective, phosphorylation is defective, the answer is B. The cell cycle will stop. The cell cycle will stop at G1. The cell cycle will stop at G1. What do we mean by this? See, let us have a look at RB gene. RB gene, you very well know it is present on chromosome 13q. Now, growth inhibitors stimulate the cell cycle inhibitors. They stimulate cell cycle inhibitors. Growth inhibitors, they stimulate cell cycle inhibitors like P16 Inc4ARF. Growth inhibitors, they stimulate cell cycle inhibitors like P16 Inc4ARF, as a result of which it is associated with a hypophosphorylated RB gene. It is associated with a hypophosphorylated RB gene, because of which there is a transcriptional block. This is broadly the RB gene mechanism. The growth inhibitors stimulate the cell cycle inhibitors, so the RB gene is hypophosphorylated. In case it is hypophosphorylated, there is a transcriptional block. Next point, growth factors on the other hand, growth factors factors activate cyclins. It activates cyclins binding to CDKs which cross the cell cycle, in turn leading to a hyperphosphorylated RB gene, which leads to transcriptional activation, So, if the RB gene is hyperphosphorylated, then transcription is activated. If it is hypophosphorylated, it is a block. So, if there is a ineffective, if the RB gene phosphorylation is defective, it is associated with a block. That is, the cell cycle will stop at G1. Next, this gets us to the last question. Which of the following plays a role in gene editing? And the answer is CRISPR. Question 200, CRISPR gene. Question number 200, the last question, the answer is B, that is CRISPR gene. CRISPR, this CRISPR-Cas9, it is a genome editing tool. Let us see this in slight detail. CRISPR-Cas9, this is a genome editing tool. And this is essential in adaptive immunity. In select bacteria, thus enabling the organisms to respond to and eliminate invading genetic material. This is the role of CRISPR gene. Next point. The following two methods can be used. Methods that can be used in practice, in medical practice. There are two methods that can be used in medical practice, which are for repair. That is, repair is done by NHEJ, that is non-homologous end joining. This is for mutations. You will be doing this in detail in biochem. NHEJ, non-homologous end joining, for mutations and homologous recombinations to introduce new sequences. Homologous recombinations to introduce new sequences. So, what is the main role of CRISPR? It is a gene editing tool. CRISPR, it is a genome editing tool, or it is a gene editing tool. So, it is a gene editing tool. So, it induces breaks in double-stranded DNA breaks. It introduces double-stranded DNA breaks. It introduces double stranded DNA breaks. Nothing major, you keep it extremely simple. CRISPR gene, it is a genome editing tool. It introduces double stranded breaks in DNA. Next point, it is helpful in select bacteria, enabling the organism to respond and eliminate the genetic material which has been invaded. Next, it is not currently used in the medical practice, but two MCQs were asked. Genome editing tool, that is CRISPR, and it also, the repair is done by NHEJ, that is non-homologous end joining for the mutations, whereas homologous recombinations to introduce new sequences. Do not overthink this. This is factual. Each word with the individual ones are important. Done. So this finishes your pathology subject wise test paper. It was a pretty balanced paper with respect to around 10 to 15% of the questions that were new, tough and non-discriminating. Around 30% of the questions were easy ones which you already knew the answer to, and the remaining were just one level above the knowledge. So in case you have any doubts whatsoever, you can simply mail them to me at sushantesoni@gmail.com. You can mail them to me at sushantesoni@gmail.com, but give me 3 to 4 days to reply. That goes unsaid. Done. Thank you, and needless to say, bestest of luck for the exams. They are just around the corner. This is already May's. May has already ended, so they are just around the corner. Last 3-4 months of study, and then life is really beautiful and rosy. Thank you and take care. Thank you and take care. Done.